Welcome to your online lecture for the wrist and the hands and fingers. I'm going to break this up into a two-part lecture. First part will be on just functional anatomy of the hand, and then the second part will be the actual pathologies that can occur to the wrist, hand, and or fingers. You all know this by now. I'm Dr. Cosby. Let's dive deep. So when we think about the function of the human hand, we kind of have to take like 2 steps back, and by that I mean 2 steps proximal. We started with the shoulder joint in the axilla, and we said that the shoulder joint was a massively mobile joint and allowed us to move in gross motor movement, so large ranges of motion. And so we sacrificed stability to gain mobility, right? And that was the shoulder. Then we kind of moved distal to the elbow, where we said the elbow was one of the most stable joints in the body. Most of its stability, 50% of that stability came from bony process. The other 50% of that came from ligamentous stability, right? And then we're finally at the distal part of the axilla, or the upper extremity, and we're going to just kind of group the joints together, the wrist, the hand, and the fingers, which really are the final links in the chain. One of the beautiful things about the human hand in particular is that it's one of the most active, intricate, and complex anatomical structures in the upper extremity. Just think about it. By way of moving the shoulder, we have to move the hand, picking up things, typing, texting, all of the intricate things that we do. We typically do them with the hand. So the hand is really one of the most active joints in the actual upper extremity, and that's important to kind of keep in mind. But most importantly, what the hand is most often known for is really kind of accomplishing both precision and power, right? And so these really small, tiny muscles that make up the hand and the fingers are really responsible for allowing us to be precise, like pointing at something directly or gripping something. So it allows us to kind of do gross and fine motor movement skills. If I didn't say this, the hand has approximately 30 different muscles crossing it to move into the fingers and to control its movements. But in particular, the distal flexors on the proximal side or palmar side of the hand really accomplish precision and grip. And then obviously we know that the proximal flexors, those at the actual elbow joint, so those flexor pronators and those extensor supinators, help us kind of accomplish the power grip, right? So those distal muscles in the hand will help us with precision, and then those more proximal large global muscles will then help us with power and grip. But I need you to just understand the importance and the role of the hand, right? It's much more than just something that we wave. It allows us to do these tasks that kind of separate us from other mammals, right? We have this thing called a thumb, which makes us uniquely and distinctly made. So let's dive into the functional anatomy of the wrist and the hands and the fingers. Our first stop is in the bony area or bony anatomy. And I've kind of dissected the hand just a little bit because I think it's important for you all to kind of see the different bones as they exist and then to add to them from segment to segment. So we're going to start in this upper left-hand corner first. We have several bones that make up really the hand, wrist, and fingers. So distally, the 2 bones that are going to do that are going to be the radius and the ulna. And remember, we talked about this in the elbow. The ulna is wider proximally and larger proximally than distally, and we can see that being depicted here. And remember that radial head, as we move proximally, is smaller or more narrow, but then as we move distally, it becomes wider. And we're going to understand exactly why right now. So the articulation between these 2 bones is known as the radial ulnar joint or the distal radial ulnar joint, right? Because we also have a proximal radial ulnar joint, which we spent a lot of time kind of discussing in the elbow segment. But what we're referring to right now is the distal radial ulnar joint. So it's the articulation, when we think about it, which is formed by kind of that ulnar head and the ulnar notch on the actual radius. So it fits in beautifully to the radius. And then on the next slide, what we'll see is they're held together by what we call as the radial ulnar ligament on both the palmar and dorsal side of the hand. But these 2 joints come together, and essentially these 2 bones in particular will articulate with what we call is the proximal row of the carpal bones. And so from right moving to left, let's go ahead and name those carpal bones. So the first one that we have is going to be the scaphoid. Next is going to be the lunate. This is going to be the triquetrum, and then we have the pisiform. So this first proximal row is made up of 4 bones, 2 of which truly articulate with the radial ulnar joint. Those 2 in particular with the radius are going to be the scaphoid and the lunate. And so we have these two bones articulating very closely with the radius. Now, in some essence, like when you look at some of the textbooks, one of the things that you will see oftentimes is that triquetrum and that pisiform typically don't articulate with either bone. So you can see they kind of sit more, in this case, medially, since it's the ulna. But we can see that this lunate here not only articulates with the radius, but then also slides over or glides over a little bit to the medial side and has an articulation with the ulna, right? So this is a really important kind of pivoting bone within the wrist, because it does articulate with the radius and the ulna, but then also has a direct articulation with the second row of carpals. So if we look here, we have a second row of carpal bones, which will include 4 bones. So moving from lateral, we have the trapezium, the trapezoid, yes, the capitate, which is one of the larger carpal bones in the human body, and then the hamate, right? And so we can see that being depicted here. From lateral, we have the trapezium, the trapezoid, the capitate, and then last but not least, the hamate. And you can see that this distal row of bones will then come down and articulate with the metacarpal bones, and that articulation between the distal row of carpal bones and the metacarpals is what we call the carpal metacarpal joint, or better yet, if we were to flex our fingers, it would be kind of the knuckle junction, for lack of better words. So all in all, we have 2 long bones, the radius and the ulna. We have 8 carpal bones, a proximal row and a distal row. We have 5 metacarpals, starting here with metacarpal number 5, 4, 3, 2, 1, which would represent the thumb. And then if we were to move over this direction, right, then we could add to that 1, 2, 3. So 3 times 4 is 12 plus 2, so 14 phalangeal bones. So you can see there's a lot of bones that come together to make up the one anatomical joint that is really responsible for precision and power. So any disruption to bony prominences, and we might see that we lose our ability to be precise in our movement, or we might actually lose our grip strength. The other thing to note is we have lots of bones that are connecting to each other. So what anatomical structure is going to, which type of anatomical structure would then keep all of these bones together? Good, you got it. It's the ligaments. And so I'll spend a little bit of time here, but of note, I will make sure you understand which ligaments are extremely important for you to have good grasp on. But as you can see, we have what are called intercarpal ligaments, which are ligaments that hold carpal bones together, right? So the trapezoid, the trapeziotrapezoid ligament, right? Which 2 bones is it going to hold together? The trapezium and the trapezoid, right? This one right here, which is known as the scapulunate, which 2 bones is it going to hold together? Right, the scaphoid and the lunate. So we can imagine that wherever there is a bone, I'll go back here, that touches another bone, you're going to have ligamentous structures that hold those 2 bones together to create stability about the wrist. The ligaments on this slide that are of importance to note would be the radial ulnar ligament. And so this is going to be the palmar radial ulnar ligament. And then we also have what we call is a dorsal radial ulnar ligament. And this is going to be extremely important, if we go back to our bony anatomy slide, at really making sure these distal long bones are held together and are stable. Because when we extend the wrist, for example, if we didn't have that radial ulnar ligament on the palmar and dorsal side, then those bones might widen, of course, right? And then we know that there's another anatomical structure that lives in between each of these 2 bones, known as the interosseous membrane. But as we move back to these ligamentous structures, I think it's important to kind of just really truly reflect on the wrist and just how many ligaments work to stabilize each of the bones within the actual wrist, right? So we have intercarpal kind of ligaments and joints. We have things that are called midcarpal. So midcarpal, going back here, if we were to look at this, midcarpal ligaments, so ligaments that will hold proximal row to distal row, right? We can see that there. We're going to have carpal metacarpal ligaments, which would hold or at least create some type of structural integrity to the carpals and the metacarpals as they connect to each other. And so all of that to say, there are lots of ligaments that can become compromised in a head injury. Now, as I mentioned on the other slide, you don't have to remember all of the ligaments within the actual hand, but there is one complex that becomes extremely important to understand its structural integrity. And that's going to be the triangular fibrocartilage complex, right? So you can say TFCC. That's what I've also heard it termed. The TFCC is an intricate structure, almost like a joint-like structure, that is created by a series of ligaments that come together to stabilize the kind of distal segment on the medial side, right? We've talked a lot about radial-carpal relationships with the scaphoid and the lunate. Remember, we talked about those two bones directly articulating with the radius. And then what we can see here on the ulnar side is, even though the triquetrum and the lunate don't necessarily directly touch the ulna or articulate with the ulna, we can see that their relationship in proximity to the ulna becomes extremely important. And here's why. In between the triquetrum and the lunate and that distal ulna, we have something called a disc, a triangular fibrocartilage disc, or if you want to think about it this way, think about it like the meniscus in the knee. It is an articular disc, which kind of is responsible for doing a couple of things, mainly the same things that meniscus do in the knee: absorbing shock, preventing bone from butting up against bone. And so that triangular fibrocartilage is kind of contained within several different ligaments, right? And we can see that here. So the palmar radial ulnar ligament, the dorsal radial ulnar ligament are really going to kind of wrap themselves around the disc itself. But then what we also can see here, and here's where we get the connection between the triquetrum and the ulna, is the ulnar triquetral ligament will connect the most lateral side of the ulna to the triquetrum. So we can see that happening here. And then the other thing that we see kind of happening in this process is the extensor carpi ulnaris tendon will kind of come around the ulnar styloid and move to its distal attachment, right? And so it creates kind of what we call is the roof of the triangular cartilage complex. So we have all of these anatomical structures which are extremely important and help maintain stability to the medial side of the wrist. That triangular fibrocartilage, as you can imagine, most often gets injured in a ulnar deviation moment where all of these structures either get impinged or slammed, but certainly can also be compromised in a radially deviated moment too, where you have a lot of stretching, in particular to maybe the extensor carpi ulnaris tendon, maybe that ulnar triquetral ligament. Or you have an anterior posterior force, and then that palmar ligament, radial ulnar ligament or dorsal radial ulnar ligament become compromised as well. So why am I spending a lot of time here on this slide? Because any compromise to the triangular fibrocartilage complex and we cause grave instability about the wrist. So as we move from ligaments and we keep adding layers, the next layer are the muscles of the hand. And so we'll spend a little bit of time here because I do think that as we dive deeper into precise movements and precision, it becomes important to kind of know the movers. And so as we orient ourselves, one thing to kind of keep in mind is there is one anatomical structure that has been dissected away from this anatomical image. And that anatomical structure, does anybody know what's missing? Anybody want to tell me? Great. If you said the palmar aponeurosis, okay, or the plantar fascia of the hand, then you would be correct. Just think about the foot. That plantar aponeurosis was extremely important for kind of holding in the four layers of the foot. Very similarly, the palmar aponeurosis in the hand does the same thing. It does have a medial band, which is mostly responsible for holding in muscles in the hypothenar eminence. It does have a lateral band, which is responsible for holding in muscles in the thenar emini, and then it has a central band, which is most often responsible for keeping in the muscles and the tendons of the flexor digitorum superficialis and the flexor digitorum profundus. So we can see already we have kind of this innate kind of thick fascia that covers the palmar surface of the hand, creating kind of a glove around the muscles that are going to be responsible for our precision moments and our strength moments in our hand. Now, of course, as we kind of remove the plantar aponeurosis, right? And you all did this in lab where you transected and reflected away the palmar aponeurosis. What you started to see were the small, very small, tiny muscles that were responsible for driving finger movements, right? So the first one that's most apparent to us is going to be the abductor pollicis brevis. So as we think through this, I'm going to highlight it here on this slide. This is the abductor pollicis brevis. The major role of the abductor pollicis brevis really truly is to abduct the first ray or the thumb, right? So as you think about that, its major role is to abduct the first ray, right? The next muscle in that group is going to be the flexor pollicis brevis. You can see that here. The flexor pollicis brevis, its major role is to do what? Someone tell me. Great. If you said flex the first ray, then you would be correct. Its major role is going to be inflection of the phalanx of the first ray. And then last but not least would be the opponent's pollicis. What do you think the opponent's pollicis is going to do? Anyone have a guess? Anyone? Great. If you said allow the first ray to move into oppositional moments or to touch each of the individual fingers 2 through 5, then you would be correct. Now, as we think through innervations, because you guys are in an upper division course, what can we say about the abductor pollicis, for example? What can we say about most of these muscles? Which nerve do you think they're actually innervated by? Someone tell me. Great. As the median nerve moves through the carpal tunnel, it will branch into the thenar eminence, supplying all 3 of the muscles in the thenar emini group. So that abductor pollicis brevis, that flexor pollicis brevis, and that opponent's pollicis. Now, as we move over to the most medial side of the hand and look at the muscles of the hypothenar emini group, some of the muscles that we'll look at first is going to be, first and foremost, the abductor digiti minimi, right? And so we can kind of locate that because we know that if we're doing something in abduction, it's usually moving the hand away from the other finger. So it's going to be the most kind of most medial muscle in this particular case. This is going to be the abductor digiti minimi. Major role is to do what? Abduct digit 5, right? So many of these are going to just control digit 5. You have your opponent's digiti minimi, right? What do you think its major role is? Someone tell me. Anybody got the answer? Great. If you said to cause a 5th ray opposition, then you would be correct. In other words, allow the 5th ray to move to the actual thumb itself. And then last but definitely not least would be what? Which muscle are we missing? You got it. The flexor digiti minimi brevis. And so what is its major role to flex the 5th ray? These muscles as a whole are known as the hypothenar emini group, and they are innervated by which nerve? Fabulous. If you said ulnar nerve, you would be correct. They are innervated by the ulnar nerve. Now, as we start to maybe dissect some of the layers of tissue and some of the layers of skin, we certainly have 2 other muscles that contribute to really finite finger movement. That is going to be the 2 muscles that I kind of alluded to earlier, the flexor digitorum superficialis and the flexor digitorum profundus. So I kind of want to draw your attention to those muscles on this slide first. So first and foremost, what we have here, and I'm going to use finger number 2 as the example. We kind of have the tendon of the flexor digitorum, both profundus and superficialis. And so as we come and we move more distal, what we'll start to see is this tendon will split. And so we'll see it split here into 2, and then we'll see it continue onto the distal phalanx, right? And so this division right here represents the flexor digitorum superficialis, right? Its major role is to kind of flex the pip and flex the MCP, or metacarpal phalangeal joint, and it's also going to flex the wrist, right? So I'll say that again. Its major role is to assist in pip flexion, to flex the metacarpal phalangeal joints, or allow us to make a fist is another way to say that. And then also it assists secondarily in wrist flexion. Now, in terms of its actual like attachment sites, where does it look like it actually attaches? Where do you think it attaches? Great. So you said, okay, Dr. Cosby, this is the most proximal phalanx. This is the middle phalanx, right? And this is the distal phalanx. So what we can see in terms of its distal attachment is what? Where does it actually come down and attach? To the sides, right? To the sides, each side of the most proximal middle phalanx of digits 2 through 5, right? Now our profundus, remember, it goes through the split and then it attaches where? Where does it attach? To the bases of the medial phalanges of the digits 2 through 5, right? Another way that I would say it is just the distal part of the phalange, so right in this region here. And this is a differential because it is going to help with DIP flexion because of its attachment site and angle of pull. It's also going to assist in PIP flexion, and then it's also going to assist in wrist flexion. So differentials, as we start thinking through what the two do, superficialis, since it attaches more proximally, is going to control mostly PIP flexion, obviously MCP flexion and wrist flexion, but your profundus, because it attaches more distally, right, it's going to assist in dip flexion and assist with pit flexion, and then also help with wrist flexion as well. And when we think about their innervations, there's something to be said about how they're innervated. That most superficial, what am I thinking? The most superficial of the two, or the superficialis, is going to be innervated by the median nerve, and that's intuitive. And most often we're taught that the profundus, because they kind of share similar anatomical positions, that it's innervated by the median nerve, but in fact it's innervated by the plantar interosseous nerve, right? Or palmar interosseous nerve, sorry. So we can see that they have, they share kind of a muscle bundle, but yet they split, and they're definitely innervated by different nerves. And as well, their function is a tad bit different as well. So those are the major muscles on the palmar side of the hand that we really want to kind of think through a little bit. The other that we see here, and let's go ahead and look at them. They're very small, intricate muscles, and I'll kind of try to highlight them. We call these the lumbricals. So we can see lumbricals here and here, right? And so as we think about the lumbricals, their major job is going to be flexion of digits 2 through 4, flexion of the MCP joints, and then in addition to, let me say that again. Lumbricals, flexion of the MCP joints, and they will assist with extension of the PIP and DIPs, right? And then we have the other set of muscles known as the palmar. Let me say that correct. Palmar interossi. What do you think the palmar interossi do? Anybody want to tell me? Based on their positioning. So let me identify them for you. Palmar interossi, right here. Palmar interosseus. What do you think it's going to do based on where it's positioned? Great. If you said it's going to adduct the first, second, fourth, and fifth digits, you'd be correct. And then it's also going to assist in flexion of the MCP with which muscle that we just talked about that does that? The lumbricals, right? So we have those palmar interossi, which will help with adduction, and we'll talk about the dorsal interossi when we actually get there. So this is the dorsal aspect of the hand, or the back side of the hand, or the hand where your skin color is, for the side of the hand where you would actually identify patient skin color, for example. This is the extensor side of the hand. That's the way that I would like to kind of think about it a little tiny bit. On the extensor side of the hand, we have the tendons of the extensor digitorum, of course, right? And we know what is the role of the extensor digitorum. Someone tell me. Great. Major role is wrist extension. The other thing that we can think about is that those tendons do cross over the wrist joint and go into the hand joint. So it assists with MCP extension. And in some ways, it assists with interphalangeal joint extension as well. The other tertiary motion that your extensor digitorum plays in the wrist is it's going to assist with radial deviation as well. So we can see that that extensor digitorum, those tendons are extremely important. They have lots of they play a major role in wrist function overall. Okay, the next muscle that we're going to look at so we've already talked about abductor digiti minimi, right? We've already talked about abductor pollicis brevis. Each of those will abduct the first ray and or the second ray. One key item here is the common tendon sheath, or the extensor digitorum kind of retinaculum. The major role of this retinaculum is going to be very similar to the triangular fibrocartilage complex. It's going to be to maintain all of the extensors kind of together, right? And any compromise or damage to that, and we start to see tendons sublux over each other, and so we'll ultimately, what ends up happening is we see them change planes and change function. So if we have any rupturing of this, that's kind of an emergency. Usually there's some type of surgical repair that will happen over time. Now, if we were to look at our snuff box, so if we were to abduct our thumb, we could look at certain tendons that actually might pop out at us. So the tendons of the extensor pollicis brevis and the abductor pollicis longus. And so let's talk about the tendon of the extensor pollicis brevis first. Its major role is to assist with first ray MCP joint extension, first ray carpal metacarpal joint extension, and then first ray carpal metacarpal kind of joint abduction. In addition to that, it is an assister to radial deviation, and that makes sense based on its angle of pull, right? But then we have this abductor muscle. We talked about the pollicis brevis, which is the shorter muscle. We also have this abductor pollicis longus. Its major role is to assist, again, with first carpal metacarpal joint extension. But then in addition to that, as the name implies, it's going to be an assister of first carpal metacarpal joint abduction as well, right? And so those become extremely important muscles to know. Why? Because they control a lot of the finite movements at the actual thumb itself. In addition to that, we have other muscles that are extremely important. The extensor digiti minimi. What do you think its major role is? Someone tell me. Great. It's going to extend the fifth ray, right? In particular, it's going to be responsible for assisting with MCP joint extension at the fifth ray, and then it will assist with DIP and PIP joint extension as well. So that extensor digiti minimi plays a major role in allowing the pinky to move up into an extended position, right? Next, we have the extensor carpi ulnaris, and then we have the extensor pollicis. We already talked about pollicis longus, I think. If not, we'll talk about it here. But that extensor carpi ulnaris, let me say that correct. What do you think that it actually does? Great, because it's higher up on the wrist or more proximal, that extensor carpi ulnaris is going to extend the wrist, but then because it sits a little bit more kind of medially, it's going to drive ulnar deviation, and we can kind of see that based on its physical orientation. And then we have the extensor pollicis longus, right? What do you think its major role is? Great, so it's going to be first interphalangeal joint extension, first MCP extension, first CMC extension. It's also going to assist with radial deviation. So we can see all of these muscles coming together either to help ulnar deviate, radially deviate, and extend the digits, right? The last thing that I want to talk about here are the dorsal interossi. So what is the role of the dorsal interossi in hand movements? What do you think it is? Great. So if we look at the dorsal interossi here, we can kind of see their fibrous orientation. And I think in lab, y'all learned this. Its major role is to assist in abduction of the third, fourth, and fifth digits, and will also assist with MCP flexion, right? Now, this is important to note that it pretty much does the opposite of our palmar interossi. So just be thinking about those things as you're kind of looking for commonalities between the two different muscle groups. So we've talked a lot about a lot of the muscles that are included in the wrist and the hand. Just some other things to note. We're looking at the carpal tunnel kind of right here, and we're looking at some of the structures that make up the carpal tunnel. And I really wanted you all to see a few different things. We have this flexor retinaculum, which covers the carpal tunnel or the area of the carpal tunnel. And then we have kind of this intricate blood supply, right? The radial artery coming down on the thumb side and kind of feeding the lateral side of the hand. We have the ulnar artery coming down and kind of feeding both the medial and probably central portions of the hand. So we can see that there's this array of vascular structures that also contribute to the carpal tunnel. So as we start to look at the carpal tunnel, I kind of want to look at it from a different perspective, and I'm going to come here. Your carpal tunnel is really composed of basically 10 kind of anatomical structures. So we have the muscles of the tendons of the flexor digitorum profundus, 4 of them. The tendons of the flexor superficialis, 4 of them. And then we have our flexor pollicis longus tendon and our median nerve. So those are the structures, at least anatomical, we'll say soft tissue structures that will kind of make up the carpal tunnel. And then surrounding that carpal tunnel, we have several carpal bones, right? So we have our hamate, our capitate, our trapezoid, and our trapezium. And if we look at this from a row perspective, then we would say that this is going to be the distal row, right, of carpal bones, creating kind of, we'll call it the the floor of the carpal tunnel. And then on the roof of the carpal tunnel, we have kind of muscles encasing, but we have this flexor retinaculum, right? So what we can see here is that these anatomical structures, if they become inflamed, for example, or if we take a blow to the wrist, there really isn't much room for the swelling to go. And so that swelling starts to go in this area and starts to compress on the median nerve, right? And the median nerve, of course, we know a few things happen, right? We know that the median nerve supplies several different muscles that we've talked about, right? The opponens pollicis, or all of the muscles in the thenar hemini, right? So that opponens pollicis, for example, would be an example of that. The abductor pollicis longus and the flexor pollicis. All right, those are all muscles that are supplied by the median nerve, but there are other muscles supplied by the median nerve. For example, the palmaris longus would be another example of that. The flexor digitorum superficialis, which we talked about already. So all of these muscles that are supplied by the median nerve become compromised, right? So as we look through at this carpal tunnel, it becomes important, and we'll go back here, that we can see that median nerve kind of coming through and living underneath that flexor retinaculum. You have the tendon of the flexor pollicis coming underneath or piercing through the flexor retinaculum, right? And so these all just become important structures that do get impinged within the actual carpal tunnel itself. We will talk about this more when we get to pathologies, but anatomically speaking, I just wanted you to kind of see that and view that and own that. Now, as we think through precision, one of the things that we have to really give credit to are our fingers, right? They allow us to be very precise. They allow us to sense the things in our environment through touch. So they are extremely important. Our fingers have these things called extensor and flexor hoods. And if I could kind of summarize this differently, I would just say lots of ligaments that are holding those phalanges together to create kind of movement mechanisms for tendons, right? Does that make sense? So imagine this is the deep flexor or the profundus, and this is going to be the superficialis, right? We can see that profundus coming through, piercing through, and then attaching to that distal phalanx. We can see that superficialis kind of coming and splitting and then attaching to the middle phalanx, right? And so these tendons need room to move to allow us to flex and then to extend. So it's almost like this intricate pulley system that is maintained by our collateral ligaments at each of the joints, right? So our distal interphalangeal joint is held together by a collateral ligament. Our proximal interphalangeal joint is held together by a collateral ligament. And believe it or not, our MCPs are also held together by collateral ligaments. But then in addition to that, we also have these things called cruciate ligaments, which we can't see really, really well, but they kind of provide support to the distal interphalangeal joint and the proximal interphalangeal joint and the carpal metacarpal joints from a load perspective. So we have all of these ligaments coming together to create pulley systems for tendons to be efficient in the finger. But then it's also important that as we switch to a different slide, that if there is a disruption in this mechanism, right? So we're looking at an extensor tendon here being able to slide and glide through these ligaments and connective tissue. If there's disruption or if there's a rupture to these ligaments or structures, then oftentimes we see finger abnormalities like mallet finger or trigger finger, etc. So this will become important when we start talking about finger pathologies. The thumb in and of itself is an anatomical structure that we could spend, I don't know, a week on by itself, but essentially we know that the thumb is what makes us unique as human beings and sets us apart from other mammals. And we can see here that we have several tendons that come together to kind of make up the snuff box, right? We have the extensor pollicis brevis tendon, we have the tendon of the abductor longus, and then over here we have the extensor pollicis longus tendon. And I imagine that you dissected this in our gross anatomy lab. And this is what we call the anatomical snuff box, and drives a lot of the thumb extension and abduction moments that will occur at the thumb, but also are responsible for allowing us to do the things like grip, grab, and create powerful movement. So knowing the anatomy of the thumb and being able to identify that will be extremely important. Now, we're going to end with talking about blood supply and nerve supply to the hand. I think it's important, especially if we take blows. So most of the flexors, we've already talked about this, are supplied by the median nerve if we're generalizing. And then a lot of the extensors are controlled by the radian nerve, and that makes sense so far. And then we have blood that has to be supplied to the hand. So we see this radial artery, and I showed that on a different slide. We can see how it will then branch off, right? It will eventually end up branching off and circling around the most distal portion of the metacarpals, right? And then we see as it comes back up proximally on the medial side that it becomes the ulnar artery. So there's kind of this circulatory system of blood flow throughout the actual hand. And we can see that the ulnar nerve and the ulnar artery and radial artery will just branch to supply the distal portions of the fingers as well. But there's this circular system that kind of happens, or circular filtration that happens. I wanted you all to see this because if we take a blow to the carpal bones, right, and there's a lack of blood flow, most often we're going to cut off blood flow to the rest of the fingers, and this will become extremely important, particularly as we talk about scaphoid fractures. Do you see how the radial nerve kind of dives more palmarly? And so there's less blood supply in this area, hence the ... and then makes its way back down to the distal thumb. And that's one of the major reasons that we see that, is because of the pathway or the trajectory of the actual radial artery itself. Now, I've hit this ad nauseum in probably different ways, but I think it's important as we go to the hand to be even more specific in our myotomes and dermatomes. So that radial nerve, as you can tell, will cover most of the thumb, right? That median nerve, as you can see, it will cover a little bit of the thumb on the palmar side. Yeah, we'll get a little bit of median nerve integration. That'll be second finger, third finger, maybe even into the ring finger. We can see that how that kind of cuts off in a dorsal kind of fashion. And then that ulnar nerve, right, that most medial portion of the hand, the pinky and part of the ring finger. And so some of you might say, Cosby, this, it seems like no matter where I look, it changes. And so I wanted to bring back the brachial plexus because I wanted us to always be reminded of one thing, especially as you get ready to prepare for the BOC exam, is that there are roots, trunks, cords, and divisions. Let me say that backwards. Roots, trunks, divisions, and cords, right? And we start with a nerve root. We start with C5, C6, C7, C8, T1. And then what we can see is that there is a converging, right? And then a diverging, and then eventually we end up with our peripheral nerves. But those peripheral nerves sometimes share nerve roots, right? And so what we're gonna see here is we're going to see crossover in signs and symptoms, right? Which is why we always say when we look at injury, it's usually not just one vertebral level. It usually involves two. So I wanted you all to be critical thinkers of that just a little bit. In essence, we can look at this lateral cord and say the musculocutaneous nerve is branching off of that, as is the median nerve. Then we can look at the medial cord and we can say the median nerve also branches off of that, but so does the ulnar nerve. So is it possible for the ulnar and medial nerve to share some myotomal, dermatomal distribution? And the answer is going to be, heck yes, Dr. Cosby, right? So this is going to end our anatomy lecture. I will work on creating the pathology lecture and get that posted for you right away.